So there's still a debate about the evidence of acupuncture for chronic pain. And some of you might be aware of this totally opposite positions, which were once published in the British Medical Journal. So you have on the positive side here, represented by Mike Cummings from the UK, that it is a relatively safe and moderate effective treatment for chronic pain. And then you have the more skeptical view here, represented by Robertson and Ernst, that it is not clinically worthwhile. So that's where we stand. They should know the same evidence behind. We will see perhaps how differently they judge on the evidence, but first I want to introduce this evidence to you. So we are talking here about an individual patient data meta-analysis. That's different from a typical meta-analysis. When I do a typical meta-analysis, I take the numbers out of the publication. In an individual patient data meta-analysis, I pool the original data of the studies into one new file and do the analysis from the original data. It's a lot of work to do this. Our colleagues in New York, Andrew Vickers and his group did it, and these calculations were possible. But there we can do much more accurate estimations from this large data set. So this is a project of a whole group. So you see here a lot of names. You also see that some people who are presenting here on this list. There's a little bit smaller group of us who are chairing this research. It got some funding from the National Institutes of Health in the United States, and there came also several publications out of this data set. What were the key questions we asked to the data set? One question is if acupuncture is better than no acupuncture. What does no acupuncture mean? It's a little bit a pooling of different control groups here. This includes a kind of standard care. Standard care is usually close to the guidelines. Then it includes usual care. Usual care is what doctors often do, but sometimes it's not really close to the guidelines. And waiting list or no treatment control. So that's all in this group. And then we have the second question, is acupuncture better than sham acupuncture? So which trials could be included into this database? These were trials on chronic pain only, including headache, osteoarthritis, musculoskeletal pain, which includes both back pain and neck pain, and the shoulder pain. We had to have proper allocation concealment. So we're only talking about randomized trials, but we're also only talking about randomized trials with a good quality allocation concealment. And pain has to be measured more than 4 weeks after the first acupuncture session. So the very short observational trials were not included. So this is the data which we have in the database. You see, it's really not small, 39 trials here with 20,000 patients, more than 20,000 patients in total. Acupuncture versus no acupuncture, this question can be asked for a pool of 16,000 patients, and acupuncture versus sham from a pool of over 7,000 patients. We have different acupuncture styles included, having fixed formulas in 9 trials. 18 trials have more flexible formulas, and totally individualized, we have 13 trials included. And also the number of sessions differ a little bit in the groups, with most trials having 6 to 15 acupuncture sessions here. So this is one of the results you get from the meta-analysis. It looks similar to another meta-analysis, which is not patient-level data. So you can express the results in a very similar way here. That's a musculoskeletal pain. And what you see here is the updated data, which means this is a publication in the Journal of Pain from 2018. We had also earlier one, it was 2012, but here more trials are included. Now it's also interesting to see if the result is similar, or if the result has changed over time. So as you can see, you have several trials in. Most trials are really also with their confidence intervals here on the side that acupuncture is better than the control. So this is the acupuncture versus usual care, or better call it versus no acupuncture control here. And we end up here with an effect size around 0.5. I'm pretty sure that not everyone in the room is familiar with what really an effect size is. It's a measure for the how big an effect is. It's a measure about the clinical relevance of an effect. And let me explain how it is usually in a very rough way calculated. So you can use the pain scores here because we have to transfer a lot of different pain scores from different trials into one similar score here so that we can do a meta-analysis out of it. And you can do this with every continuous measure. So we would have in the acupuncture group 30 on this visual analog scale, and in the usual care group we would have 42 because higher values are more pain. So you would have a difference of 12 there, and if you have a standard deviation there, 24 in both groups, the pooled standard deviation is also 24, we divide the 12 by 24, and we end up with an effect size of 0.5. So the math behind is very simple. What does this number tell me? Usually, in the interpretation stage, we say that until 0.3, it's a small effect. It's usually not seen as really clinically relevant. Over 0.3, so from 0.4 on, it's a moderate effect size, and over 0.8, it is seen as a large effect size. So it gives you an idea if this effect is clinically relevant for a patient. And 0.5 is clinically relevant for a patient. So now, let's have a look for musculoskeletal pain again, so the neck pain and the back pain pooled, and now acupuncture versus sham acupuncture. It's also statistically significant, the difference, so the effect we see, it is not by chance, but it's smaller here. It's 0.3. And again, it's the very same calculation behind here. We have the difference of 8 between the groups divided by 24, the standard deviation ends up with 0.3 and is not seen as a moderate size, so not as clinically relevant in its size. But it's still statistically significant. So these are two different things, the significance from a statistic point of view and the clinical relevance. So now let's have a look for all the results which we have seen here. So we have headaches there, musculoskeletal pain here, the osteoarthritis here. That's again versus no acupuncture, what you see here. And you see we have an effect size of 0.44 for headache. Musculoskeletal, we had 54 already. And for osteoarthritis, it's even bigger. It's 0.63. So these are all clinically relevant effects when we compare acupuncture to no acupuncture. Now we have a look for the comparison to sham acupuncture. And you see, it's getting pretty small here for headache. It's bigger for musculoskeletal pain with 0.3 and a little bit smaller for the osteoarthritis. And then we have also trials on shoulder pain here in. There, it's a clinically relevant effect size. But what we get here is it's still a statistically significant difference between acupuncture and sham acupuncture, but we have also big size of the sample here. So things get easily statistically significant. But it's not clinically relevant for the headache, the osteoarthritis, and the musculoskeletal pain. So it's about the size of the effect here. So when we transform this in responder rates, what does a responder mean? A responder is a person who has 50% improvement in his or her symptoms after treatment. This person is counted as a responder. We have 30% of these patients in this no or usual care control group, 42% in the acupuncture group, and 42% in the sham acupuncture group, and 50% in the acupuncture group. So you see, really, they're in a line. And it's also what we know from acupuncture, that even sham acupuncture has some strong effects. So between those, we see really the specific effects, the point-specific effects, the difference. Comparing usual care with acupuncture also includes the non-specific effects. referring to the discussion we had before on the cost effectiveness, that when acupuncture might cost less money, this non-specific part might get smaller. I would not expect that it has any effect on the specific part, on the point-specific part. But the non-specific part of the acupuncture effect can be affected here. So these results are very similar than the analysis from 2012, which is a good message. So it's not an acupuncture specific or non-specific effect here diminishing over time. It's a stable result. And even when we do a lot of sensitivity analysis, so when we exclude outlying trials, when we only take summary data in, when we take into account possible unblinding and take these trials out, when we impute missing data, so all the fancy things you can do with statistics and proper analysis, when we exclude those trials where patients had major co-interventions, when we only take the trials with longer measurements, the result is stable. That's also very good news. The effects even persist over time. We have some trials in which have longer observation periods. So this is acupuncture compared to no acupuncture group. And you see, this is over time here. They get a little bit closer, but not much. The difference mainly stays between the both groups. And this is also similar in the sham acupuncture groups. So it's not only a short-term effect we see here, and the acupuncture treatment already has ended, but the effect seems to stay up to 12 months here. So when we summarize, we see robust evidence for moderate effects when we compare acupuncture with usual care types. And this is very similar to other non-pharmacological interventions for chronic pain. So acupuncture fits nicely into these treatment options. The evidence for acupuncture compared to sham acupuncture, so the acupuncture point-specific effect, it is statistically significant, but it is of small size. And this effect from its size is not clinically relevant, but it seems to be a stable effect. So what are the limitations and the strengths of this approach? Usually, studies are heterogeneous. And that's also what we see in this data set. We have a lot of different patients from different countries with different control groups. And we always have some influence factors there. We tried the sensitivity analysis to at least see if they affect the result, but you never can be 100% sure. We have a large number of trials included. We have real data here. So there are a lot of conventional interventions which don't have the patient-level data meta-analysis level. So this is a very positive thing. And that's the trials, even with the newer trials and everything, that we have quite robust results here. So what does this make with the interpretation? If we have skeptics more, like Robertson and Ernst, they're looking on different parts of this evidence. They focus on the effect over sham acupuncture. That's a part they're interested in, and that's of small size. And there might be bias in it because it's unblinding there. But this means they focus only on part of the evidence. Whereas pragmatics, more like Mike Cummings or many of us in the room, we like to see the full picture of the evidence. And also the other point is if we have evidence from exercise, from psychotherapy, we also can't blind these techniques. Very often, a lot of this evidence is not from sham-controlled trials, even often not from really proper comparisons, and they are much easier recommended in guidelines, especially when we talk about low back pain guidelines from the UK, for example. And the evidence from the acupuncture effect over usual care, it's a really interesting one because there are also some trials in which show that acupuncture is, with a moderate effect size, superior to a standard care for low back pain, for osteoarthritis of the knee. So I think we also have to get a better understanding for this non-specific effect which adds to the acupuncture point. specific effect. And we have to put it more into the whole picture when we judge about non-pharmacological treatments. And there are a lot of publications out from this data set. So we have, Klaus has put some of the quotes here for you. And there are also publications showing a little bit more the effect of the control groups, which patient characteristics, which acupuncture characteristics play a role. And we are still publishing out of this data set. Thank you very much.